Claire, you were nodding your head yes. What do you think? Okay, you don't find yourself in pain as much. Sure, absolutely. Okay. I'm giving a big presentation via Zoom to like what maybe like 500 or 600 people this Friday on the effects of like pain on exercise performance and those things. And conceivably, a little bit of alcohol might make that better. Okay? Let's think about it this way. How many of you have consumed Gatorade or Powerade or something like that at some point in your life? In and around a sporting event. Okay? Yes? You guys think those things work and are ergogenic? Nodding yes. So talk to me. What's up, Mike? Tell me about that. Why do you think that would be helpful?
What I know, Gatorade has a pretty good ratio. It's probably the best modality for reloading the muscles.
Okay, so Gatorade is water, right, and sugar. Gatorade is actually a 6% carbohydrate solution, which means nothing. And we could talk about that it's 6% and it's like 4% glucose and something sucrose and those kinds of things. Powerade is an 8% carbohydrate solution. It's a little bit that way. For what kind of events do you guys think that drinking Gatorade might be beneficial? Aerobic. Okay. When we say aerobically, what pops into your head, Mike? Stuff that lasts longer than 5 seconds. Okay. Okay. So I drink Gatorade, then we're gonna have me do one squat. Maybe not that helpful. But if I'm gonna have to do like play a soccer game or something, maybe it would be helpful there. Okay. You guys know what's beer and wine made of? Other than the alcohol, what is in there? Water, carbohydrates. Okay. The type of carbohydrate and its concentration may vary ever so slightly in there. So what do you think? If I'm doing some sort of endurance-based event and I don't drink so much to where I'm going to be actually intoxicated and have an impairment in motor control and motor function such that I can't run or walk or whatever, if Gatorade is beneficial, and there's evidence that it is in certain instances, do we think that beer or wine or something could be ergogenic? And will you seem more convinced now, but you seem unwilling to commit? All of you guys should have been nodding your head definitely yes, it is ergogenic. And there's evidence. So back in before there was Gatorade, cyclists used to drink beer during long distance cycling events. Beer usually has a little less alcohol content, especially if you drink really, really kind of weak American like light beer, right? That's like 3% or 4%. It doesn't matter. I was gonna say when we lived in Mississippi, you couldn't buy like regular 6% alcohol beer or 6% alcohol like malted beverages and things at like Walmart or grocery stores. You had to go to a liquor store. They call them a package store. You go to a package store to get it. So some stuff that's that low, it could be ergogenic. Okay. Now I'll do a different one. What about coffee? How many of you had a cup of coffee this morning? Okay. Do you think your coffee could be ergogenic? Well, let me back up. How many of you drank your coffee black? Okay, Chandler and Nick, black coffee. How much? How much did you have? Okay, like a regular, like an 8-ounce cup or something, or were you talking? Okay, because my dad says he has 1 cup, and when my dad says he's had 1 cup, what he really means is like 24 ounces, like a big kind of a thing. He thinks like a pot is a cup, but okay. Nick, how about you? How much did you have?
About the same. How much is in the cake?
How much is in a K-cup? Okay, so that's about that. Okay. My other folks that had coffee, what did you have in your coffee? Sugar? Anybody else have anything in your coffee? Milk? Okay. Anybody get a little spritz of caramel or chocolate or something in your coffee? No? Okay. So what do you think? Do you think coffee could also be ergogenic? Okay. So in some ways, coffee is water and some carbohydrates. It also has another magic elixir. You know what that is? Caffeine. Very good. Okay. Of all the things that are in there, the coffee might actually make you better at doing one squat if you have it, say, 45 minutes an hour before. It takes caffeine 30 to 60 minutes to get it to reach peak concentrations in your bloodstream. So those of you that are regular coffee consumers probably intuitively know that. I need to be able to do my best at such and such a point. I better drink my coffee at this point. Okay. What about Coca-Cola? You guys think Coke could be ergogenic? Saying yes. Taylor, what do you think? Yes, no, maybe? You know? Okay. That's all right. You want to guess? Okay. It does have a fair amount of sugar, right? Okay. Liz, what do you think? I think yes, okay. Coke has caffeine, it's water. Now it's carbonated, which makes it maybe a little less appealing, okay? Carbonated and sugar. Now in the old days, you know why Coke is called Coke? You guys know what was in the original formulation for Coke? As a person that lived in Georgia where Coca-Cola is based, you have to know these things. Go to the Coke Museum. There's actually a Coke Museum. I don't know if you guys care. If you're ever in Atlanta, you can go to the Coke Museum. You know what was in it? Why is it called Coke? Cocaine. Okay? Now, I'm not advocating the use of cocaine. I'm not. However, cocaine is a stimulant, right? So if you could ensure yourself to not have a heart attack and those kinds of things, we could argue that cocaine might also be a stimulant in the same way that taking meth is a stimulant, and both of those things could potentially be good for exercise. Don't do meth, don't do coke. Please do not mistake what I have suggested, okay? Please do not. Diet pills, same thing. Stuff that has caffeine in it, or it used to have ephedrine, and then all of those things are stimulants that potentially. Okay? All right, that was good enough. Okay. We're ready to talk about diabetes. Yes? No? Maybe? All right. So we'll do this with my folks that are on Zoom as well. How many of you know someone that is a diabetic? Okay. So almost everyone in the classroom knows somebody. And then our Zoom folks, we've got a few of you guys that are weighing in. Okay, good. So of those of you that know someone that is a diabetic, how many of them are type 1 diabetics? Okay. A couple of you all know people that are type 1, okay? How many of you know someone that's a type 2 diabetic? That's the best. More of the majority. Okay, good. So diabetes is less common, especially type 1 diabetes. It's very, very rare. But diabetes is less common than cardiovascular disease. But we are going to find that of all of the chronic diseases, of all of them, that we can deal with, or that we have to deal with, or that you're going to be at risk for, due to lack of exercise, lack of physical activity, lack of fitness, and potentially obesity. Type 2 diabetes is the thing. This is the chronic disease that is going to most commonly result from a lack of those things. But it's also maybe the disease that if we do exercise, if we do have good fitness, if we do lose a little bit of weight and we can get our BMI down out of the obese range, it's also the one that we potentially can have the greatest effect on preventing or controlling, just simply by being more active, okay, and by increasing our fitness levels. All right? So that's why this is kind of an interesting one for us to kind of go through and talk about. Let me try to get this out. So some of the things on here, guys, are going to be a little bit more in-depth than I completely want you to know, and I'll try to point those things out. So Dr. Pinku, who also teaches this class, Dr. Pinku is a type 1 diabetic, and so that's his PhD is in studying metabolism and things related to diabetes, and so he is way more of an expert in all of this than I am. But he put this lecture together for the most part, so it's got a little more detail than I'll try to point that out. Okay, so diabetes mellitus is what it is called, and that comes from, weirdly, a combination of Greek and Latin. Greek, diabetes means to pass through or to siphon, and mellitus comes from sweet, okay, or honey-like. How many of you have like interned or volunteered at a PT clinic or something? At this point now. Okay, so I don't want to tell you guys that haven't yet that you're behind in life, but consider doing this, okay? But you want to be a PT tech, you want to do something, you want to volunteer? Well, if this was, say, the 1700s or even the early 20th century, you might have been the unlucky person that when someone came in to the doctor's office and they were overweight, they were sluggish, they were tired, they were having problems, you might have drawn short straw and had to be the urine tester. One of the old traditional ways to diagnose somebody as being diabetic was you had to taste their urine, and their urine tasted sweet, okay? Because it had high amounts of glucose in it, which we will talk about why that's the case. But the kidneys were excreting a large amount of glucose, okay? And so that is one of the ways. Now you could, depending upon how high it was, the urine apparently may also even smell like sweets. You might get around it from having to actually taste it, but that's the way that it used to be. So, hence the name, right? We're passing diabetes, we're passing this urine through your kidneys, or we're sort of siphoning it, and it is going to be sweet or honey. Right? Now, in the present day, what it is to understand that is wrong with a person if you have diabetes, it will explain to you why their urine would be sweet or honey-like. Okay? So diabetes is a metabolic condition. And that means not that you are going to have problems making energy per se, but it's a metabolic issue in that you're going to have a different amount or a different level of your ability to metabolize carbohydrates, to metabolize glucose or sugar, okay, compared to people that are not diabetic, okay? And so because you cannot properly maintain, right, carbohydrate and lipid homeostasis, you're either going to have some sort of insulin dysfunction, okay? And what happens as a consequence of all of that is that your body has a hard time taking glucose that you have eaten from your bloodstream and moving it into cells, so that those cells can either store it or that those cells can use it for energy. Okay? Dear God, why is my phone just blowing up? My apologies. So because of all of this, the most common symptom of a person being diabetic is you're going to have elevated blood glucose levels. So if you know anyone that is a diabetic, one of the things that they may often do is they may have to prick their finger. This is especially true for type 1 diabetics. They may have to prick their finger and check to see what their blood glucose levels are. Okay? They may check it to then see if they need to take an insulin shot or not, or kind of what else is happening as well. Okay. Even though the symptomology is the same, the outcome is the same. You have elevated levels of blood glucose. The underlying pathology, or the thing that is wrong, is going to differ between type 1 diabetics and type 2 diabetics. And we're going to end up in the same place. But what's wrong with you is going to be different. And it's the nature of that pathology that's going to make exercise such a good treatment for type 2 diabetics. Okay? So, if I am a type 2 diabetic, I have something called insulin resistance, okay? Insulin resistance. If I am resistant to insulin, what this means basically is that I make my own insulin. So type 2 diabetics make plenty of insulin. Their pancreas works correctly. But the cells that are meant to respond to insulin do not do so. Okay? So those cells are termed to be resistant. They're termed to be resistant. We'll talk about kind of the how and the why of that in the next couple of slides. Okay? If I am a type 1 diabetic, I am going to be insulin deficient. And so to be insulin deficient means I don't make enough or I don't make any insulin of my own. To be a type 1 diabetic, the beta cells in the islets of Langerhans in your pancreas are destroyed. They are no longer capable of making insulin. Therefore, okay, you eat a meal, your blood glucose level rises, the pancreas wants you to secrete insulin, but it can't make any to be able to do so. Okay? People that are type 1 diabetics, if we give them artificial insulin or an insulin injection, the target tissues for insulin still work. Okay? For the most part, type 1 diabetics, their cells, their target cells still work. They're not insulin resistant. So we have to treat them by giving them insulin. If I'm insulin resistant, I make plenty of insulin, but my tissue doesn't respond. And in some ways, that is even more insidious and more difficult to deal with than the fact that I just need to take some insulin. Okay? All right. We used to call type 1 juvenile onset. Okay? We used to call type 1 juvenile onset. Most people that are type 1 diabetes is an autoimmune disorder where the immune system attacks and destroys the beta cells in your pancreas. Okay? Therefore, you make no insulin. It was called juvenile onset. Pretty self-explanatory, I'm imagining, because in most people, it's going to start or occur when you are maybe into your early teenage years. Okay? Occasionally, people will get it like into their 20s or something like that. They'll figure it out. But most people, it's going to be in their kind of juvenile to teenage years. Okay? So, no insulin, therefore you cannot respond and take glucose up into cells. So you're going to have this elevated amount of glucose in your blood, and your kidneys will have to try to filter it and secrete it. That makes your urine sweet. Okay? We used to call type 2 diabetes adult onset. That's a bit of a misnomer now because we get some adults people are going to get the onset of this before they are adults. I apologize. So we will see kids 10, 11, 12 years old now that will be type 2 diabetics, which 30 years ago was basically unheard of. Okay? 50 years ago, it was impossible. But because of kind of changes in obesity and lifestyle and things now, we're seeing the development of type 2 diabetes in younger and younger people. And so that's why saying juvenile and adult onset is really a bit of a misnomer. Okay? All right. So what are the risk factors? We'll talk about the risk factors for each one of these. Okay? Type 1 diabetes, the biggest risk factor is genetics. Okay? Because it is immune mediated, it's a genetic, in some ways, a genetic disorder. So if you have a parent or a grandparent or a brother or a sister that is a type 1 diabetic, you are at an elevated risk. Okay? There's not a lot of lifestyle factors that are going to play into what that's going to be. Okay? Now, there is a fairly large genetic component and risk for being a type 2 diabetic as well. Okay? So, you are about twice as likely to develop type 2 diabetes if you have a parent that is a type 2 diabetic. Now, part of this is not, as we see the pathology of type 2, a lot of this is going to be related to risk of high blood pressure and risk of obesity, which are in many ways genetically mediated. Okay? So that's going to play some role. The other big issue with type 2 diabetes, okay? Obesity. This is maybe the largest driver of things for being a type 2 diabetic. About 80% of people that become type 2 diabetics are overweight or obese at the onset. Okay? I'm having all kinds of mask problems today with my mask does not want to stay on when I talk. So, 80%. This is also strongly associated with abdominal fat distribution. Okay? So, if you have or store fat in your abdominal region, okay, we call this sometimes visceral adiposity. So adipose tissue right here, kind of around your waist and your belly button area here. This is one of the reasons that we take the waist to hip ratio. Okay, abdominal fat distribution is going to be a big risk factor for type 2 diabetes. Age, being over the age of 45, is a big risk factor. Being sedentary is also a big risk factor. Oh look, obesity, age, sedentary lifestyle, these things begin to look a little bit like familiar to you guys. These look like risk factors for cardiovascular disease because indeed they are. Okay? Most people that are type 2 diabetics are also going to be hypertensive, and they very likely are also going to be dyslipidemic. So they're going to have elevated LDL cholesterol levels. So not everyone, but the vast majority of people that are type 2 diabetics also have comorbid cardiovascular disease. Okay? So these two things tend to cluster together. And we have a thing, and it's less commonly used now, but it used to be called metabolic syndrome or metabolic syndrome X. And that represents the clustering of cardiovascular disease, especially hypertension, type 2 diabetes, and obesity. We tend to see those three things cluster together all the time. Okay? All the time. Okay, so we did prove over here. Okay. All right. So let's talk about type 2 diabetics and what's wrong with you if you're a type 2 diabetic. So the primary cause of being a type 2 diabetic is an impairment in insulin signaling to the tissue. So you've got a 50-year-old person. They're a type 2 diabetic, okay? They eat a meal. Maybe they went to Olive Garden and had bottomless pasta for lunch and bottomless breadsticks, okay? They consume a bunch. They digest it. Their blood glucose levels begin to rise. Their pancreas functions normally. They release insulin, and insulin's job is to lower their blood glucose. It's to drive that glucose out of their blood into adipose tissue for storage and into skeletal muscle especially to be stored as glycogen and to use as energy. Okay? So what happens is these people get the insulin signal, but then especially their skeletal muscle doesn't respond correctly. Okay? It doesn't respond. The insulin is there and it's saying, hey, 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 let in some glucose, let in some glucose, let in some glucose, and the skeletal muscle just ignores it. Okay? It doesn't function properly. It's just going to. That's this idea of insulin resistance. Okay? So, people that are type 2 diabetic also are going to become, at times, what we call hyperinsulinemic or hyperinsulinemia. And what that means is that because their cells don't respond to insulin at the normal dose of insulin, then the pancreas begins to release more and more and more and more insulin in an effort to further try to give a signal to drive that glucose into those cells. And eventually, people that are type 2 diabetics, if it's uncontrolled and it lasts long enough, can begin to kind of wear out and lose the function in their beta cells, and they may become a type 1 diabetic later on. Okay? Okay. So about 10% of the world population has type 2 diabetes, many of which are undiagnosed. Okay? 10%. So very, very large amount of things. This is one of those diseases that its prevalence or its incidence has risen dramatically over the last 30 years, and I've got some data. Okay? All right, we talked about type 1, we talked about these kinds of things. Okay. So if you have a person that's a type 1 diabetic, and I'll tie this into things you may see in the news here, okay? You make no insulin, okay? You make no insulin. So without exogenous insulin, so without being able to inject yourself with insulin, the person that is a type 1 diabetic will die within 6 months to a year, okay? They cannot function without their insulin. And insulin, to buy it, to purchase exogenous insulin, especially if you don't have insurance, is outrageously expensive, okay? It's outrageously expensive. So $800, $1,000 a month to buy a 1 month supply of insulin, okay? That's about in the neighborhood of what we pay for daycare for Ellis. Okay? So imagine if you guys, you have insurance like Dr. Pinku does, and it's like $15 a month with the copay for the insurance. No insurance, and it's that expensive. Okay? This is a drug that people have to have or they will die. Okay? We'll talk about, I think it's Pfizer that owns, or maybe it's Merck or Pfizer that owns the patent for insulin that we have. That was given to them for like $1 way back in the day. But it's a big deal. Okay. Okay. So we talked about this. About 1% of the world population is type 1 diabetic. So about 10% of all diabetics are type 1. So the vast majority, about 90% of diabetics are going to be type 2. Okay. So weirdly, the rates of this are on the rise, and we don't really understand. We understand why more and more people are becoming type 2 diabetic because we're sedentary and we're obese. We don't really understand what's going on with type 1 diabetes. Okay, so here you can see, okay, we have one of the first humans who was ever treated with insulin. His name was Ted Ryder. Here's little Ted, a picture of him in 1922, and you will note that Ted is kind of a, we'll just call him a svelte or kind of a very lean-looking child. Here he is a year later, and he is a little fluffier, have a little more of a kind of a little chunkier youngster, which is probably better. So Ted was a type 1 diabetic, okay? And these guys here that you can see, Banting and Best were these two guys. They extracted insulin from a pancreas, and they gave it to their diabetic dog, Marjorie. They figured out that if we take insulin from a healthy dog or from a healthy person, and we feed the dog or the person a meal, and then we inject them with the amount of insulin that they need, then basically they look and function like a regular person. You can take exogenous insulin, and it works in these people's cells. So there they are. This was done at the University of Toronto. And so Ted was able to get some of the first exogenous insulin. And so you can see for kids of his age, the reason that they look so skinny is they cannot metabolize glucose. They cannot use sugar for energy, okay? And so depending upon what else is in your diet, these kids are going to have a hard time making enough energy, and so they're going to tend to be relatively skinny and those kinds of things. Okay, so this was done in the 1920s. Okay, we have since now we basically grow. They grow insulin in bacteria that produce the insulin. That was the thing where the patent was discovered, and the patent was basically not ever enforced and was sold to one of these drug companies for, the patent was sold for $1. It doesn't cost them that much. Like we could go over to the microbiology lab if we had the right vector and grow our own bacteria and extract our own insulin from over there. So if anybody, like, we've got wealthy and people that want to invest in something, we like to make our own insulin. We can sell it for a much more reasonable price to people. But that's kind of the way things go here. Okay? So let's talk about some complications. We've mentioned a lot of these kinds of things. Extended hyperglycemia, so uncontrolled diabetes. So these would be type 1 folks that are not getting their insulin, or untreated type 2. Okay? Having chronically high levels of glucose in your blood leads to, okay, cardiovascular disease, hypertension, stroke, kidney disease, but also blindness, nerve damage, and amputation. So the high levels of blood glucose leads to damage in especially small blood vessels that go to the nerves in your hands, in your feet, and your eyes. Okay? In addition to these other things. And then having to process all of the extra glucose can potentially lead to kidney damage. So if you guys work with older individuals, or you work with folks that are type 2 diabetics, what you're going to see is most of them are going to be hypertensive. They may have some kidney disease, but what they do have a lot of are these secondary complications. Adult onset blindness, okay? Uncontrolled type 2 diabetes is the leading cause of adult onset blindness. Okay? It's one of the leading causes of amputations. Okay? You get damage to the small blood vessels in your feet. You lose sensation, if you're lucky, from the damage to those nerves. The nerves don't get blood flow, so the nerves die. If you're lucky, they go numb. If you're unlucky, you develop something called a neuropathy. Neuropathy is nerve damage. Diabetic neuropathies are one of the single most excruciating things that people can experience. The nerves get damaged and they just fire randomly. And they are these afferent pain signaling fibers, these 3 and 4 afferents, and it is this apparently sharp, shooting, extremely powerful, like burning pain that you get from these neuropathies. And the best solution for some of them at times is just to amputate, rather than we give you morphine, and it may knock the edge off a little bit, but it doesn't do that much. Okay? Some of the other kind of high-powered neurotropic drugs for those things like gabapentin and stuff, they're going to help kind of calm those nerves down. Don't seem to do a whole lot for them. Okay, so even for people that are type 2 diabetics, okay, you can control it with some drugs and with some exercise and some diet stuff, and you'll always be a type 2 diabetic. But if you can control it, you can avoid a lot of these really, really nasty kind of side effects of this, probably prevent kidney disease, and then we can use the exercise and stuff to manage your glycemic control and to manage your risk for further hypertension and cardiovascular disease. Okay? The complications of diabetes are horrendous. Okay? Untreated diabetes is terrible. Okay? There's lots of really bad, really painful, really awful things that can happen. And so that's why the fact that more and more people are getting it, and a bunch of people don't realize that they have it, partially because they don't understand, also partially because in people that lack health insurance, they can't go to the doctor, they can't even figure out what these things are, then it's kind of this snowballing effect. Okay, so treatments. So for type 1 diabetics, it's mostly medication. Okay, we're going to give you insulin, and you're pretty much going to be okay. For type 2 diabetics, we want to try to do some combination of these 3 things if possible. We can, for most folks, if we catch it early enough as a type 2 diabetic, with some changes in diet and changes in physical activity, we can do a really nice job of treating and controlling most type 2 diabetes. Okay? Conversely, if your diet is pretty reasonable and you maintain physical activity from as you age, I'm not saying that you'll never become a type 2 diabetic, regardless of what your blood pressure is and how obese you are, but it's very difficult if you are a very physically active person, okay, to become a type 2 diabetic. It's very difficult, okay? And so we'll kind of talk about why that is here Okay, so there are some what we call oral anti-hyperglycemic agents. Okay, and these are going to be drugs if you're a type 2 diabetic that are going to either increase insulin secretion, or the more common ones or the better ones are going to be what we call insulin sensitizers that are going to increase glucose uptake. So there's a drug that is an insulin sensitizer called metformin that we've talked about before, right? Metformin is one of the most commonly prescribed drugs in the world, okay? And so it does a pretty reasonable job. So we give you a drug that either lets you produce more insulin in response to any amount of glucose that you can consume. That's going to be helpful, okay? But you're now having to make your pancreas work harder. The bigger issue is that if we can give you something that makes your insulin receptors on your muscle tissue work better, this is the metformin, then we can eat something, secrete your own insulin, and then we can make you function more like a regular person by giving you this other drug. And then there are some digestion modulators, things that can inhibit glucose absorption in the gut. These are a little more effective. They also make drugs, they're not that common anymore, but drugs that can, I think one of them was called Ally, or something. There are drugs that are meant to inhibit fat absorption in the digestive system. They're marketed as diet pills and those kinds of things. They're pretty nasty kind of things because you don't absorb the fat has to get excreted, and they have some pretty kind of nasty digestive potential side effects. These aren't too bad, okay? If I'm a type 1 diabetic, I take insulin. Here we have a person either injecting themselves with insulin, or here's an insulin pump, and the insulin pump is connected where you have this constant monitoring of blood glucose, and then as that changes as you eat, then the pump just knows how much insulin to release. Dr. Pinku has one of these. Other people, lots of other people, especially younger folks, sometimes will just inject themselves. I had a student in class, it's been maybe like 5 years ago. We had class at 8 o'clock in the morning, and she was a type 1 diabetic, and she did not take very good care to control it herself. It's interesting now, she's a nurse now. I wrote her a recommendation to get her into nursing school. I know that she's graduated from nursing school. But like the first day of class, she just came in and said, Dr. Black, I have insulin and a candy bar like in my backpack at all times, because she didn't always regulate herself very well overnight. And if she forgot to eat breakfast, she could become hypoglycemic. And she's like, I just want you to know, I could pass out during class. If I do, I usually have orange juice or something, like dump it down my throat, like help me, we gotta try to get my blood glucose back up. If I start feeling woozy, I need to eat. I'm like, okay, that's fine. You know, so there's all of these kinds of things. But the pump can kind of let you do that, but the pump is like in there. It's like it's stuck in your skin all the time. But those are gonna be kind of the main ways to control those things. Okay. So if you were to go to the doctor and they were to measure you, they were going to take a blood sample and try to decide if you are a diabetic or not. Hyperglycemia is a blood glucose level greater than 250 milligrams per deciliter. Remember that anything over 125, or really if you're over 125, that's considered a risk factor for cardiovascular disease. If you're in that 100 to 105 to 125, it's another risk factor. For it to be this high, you're making too little insulin in your cells, basically don't ever respond. Okay? In response to that, you're going to get this kind of changes in mood, what people call acetone breath. You begin to make ketone bodies. So people that are diabetics are almost like they're on a ketone diet. You'll convert some of those things into ketones, and so you breathe them off. Their breath is going to smell very sweet. Because they lack the ability to get glucose into cells, you see fatigue and weakness a lot. Polydipsia and polyuria, so they're going to have these high levels. So the other thing, and part of the reason that causes this acetone breath, or the ketoacidosis, is that because you cannot get glucose into your cells, one of the things the body does is it stimulates catabolism. Therefore, you're going to want to break down protein in an effort to use that protein as fuel. So So people that have untreated either type 2 or type 1 diabetes will begin to lose muscle mass as you break down the muscle tissue to use it for energy because you cannot metabolize carbohydrates correctly. Okay. All right. Do one more thing here, then we'll take a little break. Okay. The other, and in some ways even more dangerous part of diabetics, okay, and this is especially true of folks with type 1 diabetics, is something called hypoglycemia. Hypoglycemia is decreased or very low blood glucose levels, okay? Very low levels of blood glucose. This is critically dangerous. This can be critically dangerous. If your blood sugar falls too far, your brain will put you into a coma. Because if you go into a coma, then it's going to lower your metabolic rate. It's going to try to save whatever glucose that it has. Okay? So this is either from too much insulin from an injection, okay? Your blood glucose falls to under 60 milligrams per deciliter. That also leads to confusion, weakness, impaired vision, unresponsiveness. And then some of my former students would say, coma, then death. Okay? So it is a very, very serious condition. And we'll talk about kind of if you're going to prescribe exercise to type 1 diabetics, how we can try to avoid hypoglycemia. As a person nears hypoglycemia, you need to consume some level of carbohydrate as soon as possible in order to raise your blood glucose levels back up. Your brain needs the carbohydrate in order for the brain and the neurons to continue. Okay, we'll pause here. We will come back at 12:05 and continue from there. Okay? We will resume recording. Nope, maybe. Let me go ahead and okay. So, in some ways, we've already talked about diabetes is a disease of glucose metabolism, and that insulin is the primary hormone and one of the primary ways that we use to decrease blood glucose levels. So, to back up a minute from all of this, I should probably tell you guys that of all of the things that your body wants to do, regulating a relatively constant level of glucose in your blood is, or kind of this constant homeostasis of blood glucose levels, is one of the things that your body works really, really hard at, okay? The brain runs on glucose, so the brain needs a certain amount. The body never wants to deviate too far from all of that. And so when you eat a meal, and your blood glucose rises, the body wants to release insulin, do something to bring it back down to that baseline level, okay? And to do that as quickly as possible. If you haven't eaten for, say, 18 hours or even 12 hours and your blood glucose dips a little bit, the body wants to do some other things to release some stored glucose, if you have it, to try to bring that glucose level back up, okay? It wants to fight as best it can to maintain some constant amount of blood glucose. And outside of kind of what's happening when you're eating things, you have insulin as the hormone that's going to decrease blood glucose. So when you eat something, you're going to release insulin. That's going to try to lower blood glucose back down to its baseline. Okay, if you're in between meals and your blood glucose gets to be a little bit low, then you may release what we call counter-regulatory hormones. These are hormones that when they are going to be released are going to try to raise your blood glucose levels. So these are things like glucagon, which is also released from the pancreas, and is basically does the complete opposite of insulin. Epinephrine and norepinephrine, growth hormone, so GH stands for growth hormone, as well as cortisol. Okay? So in between meals, these hormones will rise. During exercise, all of these hormones are going to rise. Okay? Insulin does a weird thing during exercise. You would think, oh, my muscles need more glucose. So I bet insulin goes up when I exercise. As it turns out, it goes down. When you're exercising, your insulin release falls to basically zero. Okay? And I'll show you why in a couple of slides. It's good that it does that. If I gave you an injection of insulin and then I had you go exercise, I could put every one of you into a coma very, very quickly. Okay? I don't want to do that. So to manage blood glucose, it's kind of the weighting of these scales of justice or the scales of glucose here to try to manage and keep it relatively constant. Okay? So insulin is interesting because as blood glucose goes up, it's going to drive glucose into cells. Insulin is also going to be somewhat anabolic, and it's going to promote the growth of tissues, adipose tissue and skeletal muscle among them. Okay? It's also going to have some effects on your liver. So that's what goes on there. Now, in skeletal muscle, we're going to break this down. Really, we're just going to focus on what happens for the most part in skeletal muscle and systemically on the action. So when you release insulin, insulin binds to its receptor on skeletal muscle. So hormones work by binding to receptors. You guys remember that from human phys? Yes? Right? We're not going to talk about the different kinds of hormones, right? If you have peptide hormones or if you have lipid-based hormones and those things and where the receptors are. But insulin binds to a receptor on the surface of skeletal muscle. That is going to cause skeletal muscle to bring something called GLUT4. GLUT4 is a glucose transporter. Your skeletal muscle has GLUT4 stored in it. It's just sitting around in there. Insulin binds, and it tells that cell, hey, bring these GLUT4 molecules up to the membrane. Those GLUT4 molecules then are going to grab glucose as it floats by in the capillaries and bring it into the cells, thus lowering down blood glucose levels. Okay? So that signals GLUT4 translocation, glucose uptake, and then if you've got extra glucose in your cells, it's going to promote the synthesis of glycogen, which is the storage molecule in skeletal muscle for sugar, okay, for glucose. So adipose tissue and liver tissue are also sensitive to insulin, and they're going to try to take up glucose into those tissues. So if you get a big insulin spike and you eat too much, then you're going to drive a lot of that glucose into adipose tissue, and it's going to make new adipose tissue. Okay? Liver use and things, you're going to try to store some glycogen in your liver, so it needs to be replaced to some extent. If we get overexpression or too much insulin and too much glucose going to the liver, you can get what's called fatty liver disease, which is also going to be a problem. But systemically, okay, insulin drives glucose into these tissues, especially skeletal muscle, that lowers blood glucose levels. Okay? And that can partially then lead to increases in protein synthesis and growth of different tissues. Okay? So here is what we would call insulin-stimulated glucose uptake. My insulin molecule comes in, it binds to its receptor through some fancy signaling. Then it tells these vesicles that contain GLUT4 to move from inside the cell out here to the membrane of that cell. Here we're going to put the GLUT4 into the membrane, and then glucose that's floating by in a capillary is going to get pulled inside the cell via GLUT4. Okay? Now, this is the simplified way of looking at this. What's actually happening with insulin signaling looks a little bit more like this. Okay? So these are going to be, here's our GLUT4 molecule, there's glucose, here's our insulin receptor, here's all of these downstream intracellular signals and things that are going to be related into the midst of all of this. Okay? So when you look at it this way, there's a lot of shit that can go wrong if insulin doesn't work correctly. Okay? Or as you become insulin resistant, insulin binds to its receptor, but somewhere down here, one of these little things gets messed up, and we can't move the GLUT4 very efficiently to the membrane. Okay? You guys don't have to know all of this. I do want you to understand, as we back up here, I do want you to know this. Insulin to its receptor, GLUT4 then moves to the membrane, GLUT4 brings the glucose in. As the glucose in the blood goes down, the insulin levels go down, there's going to be less signal to send the GLUT4 here, then the GLUT4 gets picked back up and recycled back into its vessels. Okay? You don't have to know all of this. Okay? As you look at all of this, though, you will note that insulin has some things signaling here through AKT and mTOR, which these are the primary things that drive skeletal muscle growth. Okay. Also, wait, am I missing it? There should be an interaction with PGC1 alpha on here, which helps to stimulate the growth of mitochondria as well. But basically, as you become insulin resistant, something happens that's going to block some of this signal that's going here to the left, okay, from the base of the insulin receptor over here to these GLUT4 vessels. Something there gets messed up, okay? We think it has to be over there because I'm a type 1 diabetic and I do resistance training. I don't make any insulin, but I can still get pretty adequate muscle growth out of all of that. So it's got to be something about how we're getting over here. Okay? So that can get messed up. So if I don't have insulin, let's just say, I don't immediately die if I'm a type 1 diabetic. Or if I'm insulin resistant, okay, and I can't drive glucose into my cells with insulin, I'm a type 2 diabetic, again, I'm still able to function for a while. So there must therefore be some backup mechanisms. There must be some other ways that we can drive glucose out of your bloodstream and into especially skeletal muscle. Okay? So there are multiple other kinds of these glucose transporters. There's something called GLUT1, which is always going to be active. The one that we're going to come back to and talk about is the second one, contraction-mediated GLUT4 translocation. Okay? And then there's this idea of these counter-regulatory ones. So what I want to tell you guys, though, is about this one, about contraction-mediated GLUT4 translocation. Exercise or muscle contractions are said to have what we call an insulin-like effect. Contracting skeletal muscle works just like insulin, hitting it with insulin. Okay? We could ask Megan to stand up and do squats for us for the rest of class, and we could immediately begin to, in the muscles that are contracting, we'll start sending GLUT4 out to the cell membrane and try to grab glucose from its kind of passing by. You ever feel sleepy after you have a big meal? Right? If you want to avoid that, eat and then go for a walk. Okay? You can prevent some of the insulin spike that's going to cause some of the sleepiness. But we don't understand how it works. They've been working on it for almost 50 years. When they figure it out, it will win a Nobel Prize, I promise you, because it will basically mean that we have found a way to cure diabetes. But exercise, somehow, in the absence of insulin, exercise activates this pathway over here. Okay? Some kind of force transmission along the cell membrane. Something happens with exercise that stimulates this, and you contract the muscle, and magically GLUT4 moves to the cell membrane. Okay? We don't know where in that process it works. We don't know where the activation happens and those things, but we know that it works. Okay? So, exercise drives glucose into cells. That's good, right? We want that. The cell needs the energy to do things. So the upshot of this is, I'm a type 2 diabetic. If I exercise, I can lower my blood glucose levels just by exercising. I don't respond well to insulin even though I make it, but if I exercise, I can counteract some of that effect and I can drive it in. Conversely, if I'm a type 1 diabetic and I go and exercise and I've mismatched the amount of glucose that I've eaten, and when I had an insulin shot, I may get this double dose of I just took some insulin and now I'm going to go and exercise and I'm going to get GLUT4 moved out by exercise, GLUT4 also moved out by insulin, and I may be in a great danger of dipping or dropping my blood glucose levels very, very far. Okay. Does that make sense, guys? Okay. Does that make sense? So, if you take the fact that exercising is going to bring glucose in, then it makes sense why exercising drops insulin levels. Exercising chronically also does something else good for your insulin receptors. You take a person that is a type 2 diabetic, for the most part, I could take any one of you that has normal insulin receptor function. If I make you exercise, I have you do any kind of exercise, walking, running, weightlifting, whatever it is. Exercise makes your insulin receptors function better for about 48 to 72 hours. So exercise improves insulin resistance. So because of this, I can drive glucose in via exercise, and I can make my insulin receptors function better. We can use exercise and physical activity as a way to treat or prevent people from becoming type 2 diabetics. I'm a type 2 diabetic, my receptors don't work very well. Go for a walk. Your receptors immediately work better. Okay? It's beyond the scope of this class for me to try to kind of tell you guys some of the hows and whys that we know as to how exercise improves insulin receptor function, why it would be a good thing for exercise to do all of that. But suffice to say that it does. Okay? It does. And so if you take a person who's a type 2 diabetic, you exercise them, their receptors work better for about 2 days. So within 2 days, go exercise again. And within the next 2 days, go exercise again and again and again, and voila, if I'm just active most days or about every other day, I can keep this increased function in my insulin receptors, and therefore I can use that as a way to at least partially treat some of my insulin resistance. Okay? Some. So if you can catch people early on as they're becoming a type 2 diabetic, and you can get them to be more active, we can go a long way to preventing them from kind of having that get worse. And if you match that with some changes in diet, where maybe we stop eating gummy bears quite so much, you lower a little bit of the glucose content in the diet, you ramp up kind of more of the higher fiber things, okay, and those things, then the combination of those two things can let me have a pretty good chance at dealing with and treating type 2 diabetes. Okay. We're not really going to talk much about the counter-regulatory hormones. I just want you guys to know that these things are going to actually cause glucose to be released from its storage sites in the liver and in skeletal muscle from glycogen and into the bloodstream, so they're kind of the opposite of insulin. Okay? But that's really all that I want you guys to know. These are just some graphs showing kind of what happens with those things. Okay. Why is it important? Why is it blah, 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 blah. Okay. So from here on, we'll skim a couple of things, but you guys are not really, really responsible. This is some of the stuff that Dr. Pinku puts in his class that he wants them to know that I think is important and it's interesting, but it's a little beyond where I think we need to be in class. Okay? And so this is just showing the response basically of a person to a bout of exercise here in gray. What you've got, this is plasma glucose and this is plasma insulin levels. But what you will note here basically is these are people, the black is a person that's a type 1 diabetic, and then here's a healthy person. So that while they're exercising, I just want you to know they normally have higher blood glucose levels. They exercise. A healthy person can maintain blood glucose levels during exercise because their hormones work correctly. But here's our type 1 person. It's falling because the exercise is pulling it in, okay, which is in some ways a good thing. And here's the plasma insulin levels. You will note that in a healthy person, exercise starts, insulin levels will bottom out, but yet, right, in our type 1 person, they're going to stay relatively constant because they just don't make much. Okay? Okay. How does exercise work? This we've talked about. Okay. increases this, boom, we talked about these things, lasts up to about 72 hours. Okay. Can we use exercise as a therapy? And the answer, of course, is yes. Okay. So, just some brief things on exercise as benefits. So if we were to prescribe exercise to a person that's a type 2 diabetic, okay, in general, we want to look at their cardiovascular risk factors, and beyond that, they can safely do pretty much whatever a normal person can do. Okay? As long as they've got physician's clearance and things, then they're going to be fine, right? We're just going to want to make sure we're going to try to promote weight loss in them. As long as they don't have any other complications, they can do resistance training or running or biking or intervals or CrossFit or whatever it is that they want to do. And they should see some improvements in their glucose control from all of that. Okay, here's the American Diabetic Association's recommendations from 2018 for physical activity. You will note it looks basically identical to what the ACSM recommendations for a healthy person. 150 minutes of moderate, right? No more than 2 consecutive days without activity, so that we can stay in that range of having our improvements in glucose and insulin signaling. We want you to do resistance training and what? Okay? Okay, so this is the stuff for type 2. What about if I'm type 1? The real big thing for a person that is a type 1 diabetic, they don't really have any limitations, okay? Provided they don't have any other comorbidities. What we really want to check on with these people, though, is we want to make sure that if they're going to exercise, that they consume some carbohydrate before they exercise. That's the key thing, okay? We are worried that they will exercise and their blood glucose will fall too much. So always, 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 always have a candy bar, okay? Have a glass of orange juice, have something with glucose in it before they go and start to exercise, just to be safe. Okay? That's the only real kind of big thing that we're going to look at. Okay. Their recommendations are basically the same. General considerations, you guys can read through all of this. It's really, really all about the same. Special considerations, don't worry about this kind of stuff. It's just bebopping through here. There's all this anaerobic exercise and like weightlifting exercise. This was some interval stuff in these people. Don't worry about this. Dr. Pinky loves all of this because he studies these kinds of things. And it's really interesting, but it's more than you guys need to know. I'm just going to go through here. Summary, take-home message. That's pretty straightforward. Okay. So as I said, a lot of the stuff in the back end, it's there. Look at it. Follow your study guide. You'll stay on what I really want you to know versus some of the other stuff. Okay. Anybody have questions about it? Tim. Oh, no. That means that we must have just moved when I need to look at which one is on there. I'll do that when I get back to my office, okay? But no, if stuff that was on the last test, then no, you're not going to be responsible for it again. And if it has the research method stuff on there, we don't get that. I will take a peek at that when I get back to my office and make sure that it's only covering. And I may have just uploaded the wrong one. The second test is always, and the third test are always weird, based upon kind of how far we go for each class. All right. How many of you need some assistance or want me to talk about how we use the skin fold equations to calculate percent body fat? A couple of y'all? Okay. So for my folks that are on Zoom as well, what I'm going to do is I'm going to pull up the equations. But anybody that feels pretty good about that, then you are certainly free to go if you would like. Several of you guys have already sent me your data. You're welcome to go ahead and take off. If you've done it once, but you want to stay and hear me talk about it, that's also fine. But I will do a little bit I'll do a little bit of that. Okay? So what I'm going to do is I'm going to stop sharing for just a minute while we record, but I'm going to pull up the lab. We'll go through how we use these. All right, so if you will remember correctly, we did not do this, but the way the skin folds work is you're going to take your measurements from either the correct 3 sites or from all 7 sites. Okay, the 3 sites are going to differ whether or not you're a man or a woman. So you're going to take those numbers, and we're going to do something that's called a sum of the skin folds, which means we're just going to add them together. Okay? And then once we get those numbers, we're going to plug them into a couple of different equations and use that to calculate. So on the lab, what you can see is that, right, we're going to have a female-specific equation for 3 sites and 7 sites, a male-specific equation for 3 sites and 7 sites. These top equations are called, one of them is the Jackson-Pollock equation, or it is the Jackson-Pollock equation, my apologies. And we're going to get, from the Jackson-Pollock equation, you're going to get this BD stands for a body density. So remember that skin folds is based on the concept of densitometry. So we're going to use those sums of skin folds plus your age. Okay? And from that, we're going to calculate a body density. Once we know your body density, then we're going to plug that body density into, I prefer that we use the Seery equation for body fat, okay? Which is basically 495 divided by body density minus 450. You can also, and some of you guys have done this, you can use the Brozic equation if you want. You're going to get a number that's basically the same. Okay? So what we need to do is, if you guys look up here, okay, is for each equation, you're going to use either the sum of the 3, okay, the 3 sites that are going to be specific. So for women, that's triceps, thigh, suprailiac, and your age. In the 7-side equation, it's the sum of all 7 skin folds plus your age. And so once we have all of these, and if you're a guy, you use the other equation, and you're going to use the chest, the abdomen, and the thigh. Once you get this, it becomes algebra. And where most people mess up is they forget their order of operations when they're doing algebra. Okay? So, for instance, let's take the female site here. The female 3-site body density equation. So you've got 1.099, okay, and you're going to subtract from that the sum of the skin folds, so x1 multiplied by 0.00099 plus, okay, 0.000023 multiplied by your age squared, and then you subtract out 0.001392 multiplied by your age. Sorry, this is the skin fold squared, that's your age, my apologies, okay? Where most people make a mistake with this is you have to do the things, you have to do the multiplication and the squaring and multiplication first, then you can do the addition and the subtraction. The other big issue is we need to round these things to at least 4 decimal places. Okay? At least 4 decimal places. All of you should get a body density somewhere between 1.099 and basically 1.0. But whether it is 1.087 versus 1.082 makes a really big difference. Okay? That may be 3 or 4 percentage points when we go to calculate the percent body fat. So we need to make sure that we're going out, I would say to go out to 4 decimal places. Okay? So you can do that. You're going to get 1 body density from your 3-side equation. You're going to get 1 body density from your 7-side equation. They may or may not actually be that close to each other. If you are a person, say you're a woman, and you have less body fat than what would be expected in the particular 3 sites that are used in the 3-side equation, you may have a significantly higher body density from the 3-side equation than you do from the 7-side equation. Or if you happen to store more fat in those 3 sites than common average, you may have a lower body density than in the 3-side than you will on the 7-side. Ideally, the 7-side is the most accurate one, because more sites is going to be better. We're going to calculate those 2 things. Okay? Once you get the body density, you plug that into the series equation down here, and you're going to get a percent body fat out of it. So you should get a density number. Most people are going to be somewhere between like 1.03 and like 1.08, somewhere in there for body density. Okay? And so that's going to be really, really important. You need to be very particular and very specific. Okay? So that's how we use those. You guys have questions?
So you want us to report back to you, you want both the 3-side, 7-side, and then 1 of the fat percentage or both?
Just the serum fat percentage. It's all done, just the serum fat percentage. Anybody left on Zoom have a question? Nope. Then if between now and noon tomorrow you guys try this and you get a number that looks weird, then just shoot me an email or a text message and let me know. Stop sharing.